I'd like to call the meeting of the Military Construction and Veterans Affairs and Related Agencies Subcommittee on Appropriations to order. This morning, we welcome Dr. Patricia Hayes, the Chief Consultant for Women's Health Services, and Dr. Susan McCutcheon, the National Mental Health Director for Family Services, Women's Mental Health, and Military Sexual Trauma. The topic of our hearing today, which I am really glad we have an opportunity and the time to take, so there are some byproduct benefits of the government shutdown and the president's budget being late, is that we have an opportunity to slow down for a minute, take a step back, and be able to have some really important discussions about the issues that we need to consider before we actually start writing our bills. And access to VA healthcare for women is really, really critical, and one that I think is important to shine a spotlight on. Women have been serving in the military in various capacities since World War II, and the number of women in the military has continued to increase over the years. Women have faced challenges in gaining access to combat roles. It was not until 2016 that all combat positions were finally even open to women. 2016, let's let that sink in for a minute. And just like in the battle space, women face unique challenges when they leave military service and seek access to health care through the VA. Just like men make up the largest population in the military, the VA is dominated by gender-specific care programs for men. While the VA has taken great strides to increase access of care to women, more needs to be done. Women and men serve with equal commitments in the military, and we need parity when it comes to access and gender-specific care options at the VA. Funding for gender-specific health care for women has remained stagnant at around $500 million over the past few years. Yet women are the fastest growing veteran group. They make up about 9% of the current veteran population and are estimated to make up 15% by 2035, and higher than that in some locations. More resources need to be invested to increase women veterans' access to care. Women should be able to walk into any VA facility and receive a basic standard of care, and that's not possible now. Having women doctors and gender-specific care programs for women at every single VA facility is the absolute least we can do, and we are not currently providing it. On the bright side, telehealth programs have greatly expanded access to care, primarily to veterans in rural or remote areas, and even in places where it's not, where the service is remote, but the location where the veteran isn't. VHA provides gender-specific care through telehealth services, but the VA cannot rely only on telehealth services to expand care to women veterans. Women veterans deserve in-person, up-close and personal care as well. Like everyone around this table, the mental health of all veterans remains a top priority for me. Women veterans are twice as likely to commit suicide compared to non-veteran women, and the suicide rate for women veterans is climbing much faster than for male veterans, with a 45% increase from 2005 to 2015. There they are. Thank you. I have really bad allergies, so sorry about that. Women who have experienced military sexual trauma are also more likely to commit suicide, and we must do better to protect veterans who experience MST. While VA has made mental health its top clinical priority, we need to dramatically reduce the numbers in veteran suicide rates and start seeing effective results of the VA's mental health programs. Dr. Hayes, there you are, sorry. Dr. Hayes, thank you again for being here today, and I look forward to your testimony and discussing these important issues with you and Dr. McCutcheon. And now I'd like to recognize my ranking member, Judge Carter.
Thank you, Madam Chairman. Very pleased to have you here today. Thank you for being here. I know this committee has heard me say several times, my district is ranked 7th in the nation for military retirees and survivors. It has the greatest number of veterans in all of Texas, and many of these veterans are women. More and more women are serving in the military, and we need to ensure that when they leave the services and become eligible for veterans benefits, the appropriate programs and services are available to them. As I said in our hearing Tuesday, we have no excuse for not giving our veterans the very best. And what you're working on is important to ensure that. Dr. Hayes and Ms. McCutcheon, thanks for your work to honor and support our women veterans. Welcome to our subcommittee. I'm looking forward to your testimony. Thank you.
Thank you, Judge Carter. And now I'd like to recognize the full committee chairwoman, Nita Lowy.
Well, thank you to Chairman Wasserman Schultz and Ranking Member Carter for holding this important hearing, and I'm very pleased to welcome Dr. Hayes and Dr. McCutcheon before the subcommittee this morning. This subcommittee must address the challenges facing the Department of Veteran Affairs in delivering care and benefits to the men and women who have faithfully served our nation. As the number of women veterans increases, and with service academies reporting record number of female cadets and larger numbers of women entering ground combat and special forces roles, the development of specific, more diverse healthcare needs are critical. It is imperative that we focus on the women veterans of today and tomorrow, ensuring equitable access continues throughout every stage of life. Dr. Hayes and Dr. McCutcheon, I am encouraged by some of the steps the department has taken with support from this subcommittee, improving access to, I could use a little health care today. Improving access to infertility treatments, maternity, newborn care, access to emergency contraception, women-tailored prosthetics, and the Tele-Women's Health Program are just some of the improvements. While these are encouraging, I am concerned there are systemic challenges at the VA that may divert attention from these and future efforts. The VA recently reported almost 43,000 job vacancies across its healthcare system as of December 2018. This represents a 14,000 increase from 2017. With demands on the VA only increasing, these shortages are a troublesome trend. The system-wide strain will likely impact services our women veterans now rely on, ranging from primary and reproductive to mental health and long-term care. Shortages of this magnitude may stall progress, lead to reductions in access, or delay preparations for a larger number of aging women veterans. The VA must maintain a focus on women veterans' needs, regardless of what challenges it faces now or in the future. So I appreciate your appearing here today. I look forward to your testimony, and I thank you for your commitment to our nation's veterans. Thank you.
Thank you, Madam Chair. We'll proceed with the standard 5-minute rounds, alternating sides, recognizing members in order of seniority as they were seated at the beginning of the hearing. And I would ask, as always, for members to be mindful of asking your question, leaving enough time for the witnesses to answer. I haven't seen the majority leader notice, so I'm not quite sure what time last votes will be called, but knowing it's a getaway day, if everyone is comfortable doing one round today, and then we can take other questions for the record, and hopefully we won't get interrupted by votes. So I'll begin. I have a lot of questions, and actually I think, oh, I'm sorry. I have so many questions that I'm eager to ask them before you begin your testimony. And it was a long day yesterday, so forgive me, I'm suffering from lack of sleep. Please proceed with your testimony.
Good morning, Madam Chair.
Dr. Hayes.
Good morning, Madam Chair Lowy, Madam Chair Wasserman Schultz, and Ranking Member Carter, and distinguished members of the subcommittee. I appreciate the opportunity to discuss the high-quality care and support that VA is providing to our women veterans. I'm accompanied today by Dr. Susan McCutcheon, VHA's National Mental Health Director for Family Services, Women's Mental Health, and Military Sexual Trauma, and I should add that I am the Director, essentially, for healthcare delivery for the VA. The number of women veterans who are enrolling in VA healthcare is increasing. We're placing demands on VA's healthcare system. Women make up 16.2% of today's active duty military forces and 19% of the Guard and Reserve. And based on the upward trend of women in all service branches, the expected number of women veterans using VA healthcare will continue to rise rapidly, and the complexity of injuries of returning troops is also likely to increase. More women are choosing VA for their health care than ever before. The number of women veterans using VHA services has tripled since 2001, growing from under 160,000 a year to 500,000 a year today. To address the growing number of women veterans who are eligible for VA health care, we are strategically enhancing services and access for women veterans. Every VHA healthcare system across the United States has a full-time women veteran program manager tasked with advocating for the healthcare needs of women veterans using that facility. Many residencies in women health with didactic and practicum components have been disseminated system-wide to enhance clinician proficiency, and since 2008, over 5,800 healthcare providers have been trained in our national program. VA has enhanced provision of care to women veterans by focusing on the goal of making sure we have women's health primary care providers at every site of care. VA has at least 2 women's health providers at all of our VA's healthcare systems. In addition, 90% of the community-based outpatient clinics have a women's provider in place. VA has implemented healthcare delivery models that ensure that women receive equitable, timely, high-quality primary health care from a single provider and team, thereby decreasing fragmentation and improving quality of care. VA boasts a wide range of services to women veterans, including comprehensive primary care, gynecology care, maternity care, specialty care, and mental health services. Additionally, recent legislation authorizes in vitro fertilization and other infertility testing and treatment for married veterans with a service-connected disability that results in infertility. VA has witnessed a 154% increase over the past decade in the number of women veterans accessing VA mental health care. Over 40% of our women veterans who use VA have been diagnosed with at least one mental health condition, and many also struggle with multiple medical and psychological challenges, including trauma-related difficulties. To ensure that VA mental health providers have the skills and expertise to meet women veterans' unique and diverse treatment needs, VA has developed innovative clinical trainings to strengthen mental health access services and services to our women veterans, such as the new Women's Mental Health Mini-Residency. Unfortunately, some women experience sexual assault or harassment during their military service and may struggle even years later with its after effects. VA services for military sexual trauma, or MST, can be critical resources to help them in their recovery journey. VA provides free care, including outpatient, residential, and inpatient care for any mental or physical health condition that's related to MST, and eligibility is expansive. Veterans do not need to have reported their experiences at the time or have any documentation that they occurred, and they may be able to receive free MST-related care even if they're not eligible for other VA care. In addition, every VA healthcare system has a designated MST coordinator who can help veterans access MST-related services and programs. Since 2007, there has been a 297% increase in the number of women veterans receiving MST-related outpatient care, indicating the positive impact of these efforts. VA is proud of its high-quality health care for women veterans. Ongoing quality measures show that women veterans are more likely to receive breast cancer and cervical cancer screening than women in private sector health care. Unlike other healthcare systems, VA analyzes quality and performance measures by gender. This has been key in the reduction and elimination of gender disparities in important aspects of health screening, prevention, and chronic disease management. Since 2014, we've tracked access by gender and identified small but persistent disparities in access for women veterans, who overall are waiting longer for appointments than male veterans. To mitigate this disparity, VA has identified sites with longest wait times for women veterans and is working directly with those sites on initiatives to improve access, including designating more women veterans health providers through hiring and training and improved provider and team efficiency. In addition to all this primary and specialty care that we've delivered, we deliver via telehealth to women veterans in rural areas of the country and in geographical areas where there's a shortage of providers. Women's Health Services has also worked to ensure the inclusion of women's pharmacists in recent initiative to expand the availability of pharmacists via telehealth. VA continues to make significant strides in enhancing the language, the practice, and the culture of the department to be more inclusive of women veterans. These gains would not have been possible without consistent congressional commitment in the form of both attention and resources. It's critical that we continue to move forward with the current momentum and preserve the gains thus far. Your continued support is essential to providing this high-quality care for the veterans and their families. And Madam Chairwoman, this concludes my testimony. My colleague and I are prepared to answer any questions.
Thank you, Dr. Hayes. Appreciate both of your service and for your testimony. We do have an increasing number of, a significantly, dramatically increasing number of women veterans. The need to access VA care it increases with it. So according to the Congressional Research Service, CRS, the number of women veterans that accessed VA care in 2005 was about 238,000. By 2015, that number increased 46% to almost 456,000 women veterans receiving care. So I'd like to know how the VA is evolving to support the ever-growing number of women in the veteran population, particularly because the funding that has been flat, essentially stagnant, $500 million, and to me that cries out for an increased amount of resources. So how can VA properly support the increase of women accessing care without providing additional resources?
Thank you for that question. You're absolutely right. We've continued to experience what I call a tsunami wave of women veterans over the last 10 years. And the numbers reflect actually the net per year. So we're talking about lots and lots of women who come, some leave, many stay. Women are staying longer and longer. What we've actually done that has been most specifically to address it is to develop this primary care model, that wherever a woman comes for care, there will be a designated women's health provider. And we've grown from having very few of those and having them only in women's centers in the larger facilities to now having at least 2 at every medical center. And unfortunately, we're still at only 90% at the CBOCs. We've been working on that and working on that. This year, one of the ways that we've addressed that specifically is we're taking the training in a mobile way to the CBOCs. So we take the team out there and we stay at the CBOC and train them.
And I'm glad that there are creative ways that you're trying to make sure you reach more women, but I'm specifically asking you, are you receiving, do you need additional resources? I mean, because I don't know how you don't, given the explosion of women and the fact that we aren't even reaching all the women that we should.
Well, I must clarify that the money that we get goes into the medical services and it goes out as VERA dollars to every site. So it is distributed based on the number of women and men who are at that site. And the VERA model is obviously one that you're familiar with. And so in that sense, the more women that are there, the more men that are there, presumably the VERA dollars would go there to meet that increased demand. In specifically for the area of things that come to my level, it also has been fairly stable, and we are challenged to continue to offer all of these trainings and do the things that we need to do for the expanded demand.
Then maybe the system isn't working properly in terms of the way dollars are distributed, because if we are having trouble getting women access to gender-specific care, and we're at flat funding, distributed based on the number of women at a particular facility, then perhaps we're not allocating the funding in the right way. So I'd love you to think about that and follow up with us. I have a lot of questions, so most of them will have to be taken for the record because of our vote schedule. I do want to focus on women veteran suicide rates, which has had a 45% increase since 2005, between 2005 and 2015. Any loss of life is obviously horrific, but what effort is the VA making to research the causes for women veteran suicides, given that the women veteran suicide rate is increasing far more dramatically than men? And how do you cater your mental health programs to women based on their previous gender-specific traumatic experiences as compared to other women, for example, who did not experience MST?
That definitely is Dr. McCutcheon's expertise.
Okay.
I really can't speak to what they're doing to researching the causes, but certainly I'd like to talk about our clinical programming.
Is there someone who can answer that question for the record? Because I do want the answer.
The Suicide Prevention Office.
Okay.
In Office of Mental Health Services.
If you could help us get that information, that
Sure,
would be helpful.
absolutely, absolutely. So we actually, within the continuum of mental health services, have specialty programming that targets problems such as PTSD, addictions, MST, which there is a known suicide risk. We also have universal screening programs. So every veteran that comes to the site is universally screened, including MST. And so we have that early identification so we can refer to services. We offer evidence-based practice services at every VA medical center across the country. And such evidence-based practices like cognitive processing therapy and prolonged exposure are the gold standard for PTSD treatment. And they also show research of impacting suicide risk. In mental health services, we've recently developed this innovative portfolio of services. We now provide training in collaboration with Women's Health Services on multidisciplinary eating disorders training. And there is a link between eating disorders and suicide. And so what we have now done is we train teams that includes a physician, a therapist, and a dietitian to address our veterans with this disorder. And even though this is somewhat gender neutral, we do see more women with this. We have MST-related programming at every VA medical center. We have an MST coordinator at every medical center to make sure that there's coordination of services. We've also just recently rolled out something called STARE as a training called Skills Training, Effective and Interpersonal Regulation. And we know that emotional dysregulation is a cause for suicide. And so this is a new training that we have disseminated throughout VA. And one of the things we find with our trauma individuals that they have problems with interpersonal relationships and emotional regulation. So this is something that we can provide for our trauma folks that is different than trauma exposure. And so many of our women that come in aren't really ready for this, but skills trainings help them with this needed area.
Dr. McCutcheon, I'm sorry, I'm way past my own time, having expired.
Okay.
So I appreciate your input. But what I would like to, and we're only going one round today, but there's so much more to talk about with this. I think it'd be really important for the VA to come and speak to the Women's Caucus, particularly about the range of issues that are important to women accessing care at the VA. And then we can drill down into some of these issues like MST and suicide prevention in a little more detail. And we can do that beyond just the scope of the Appropriations Committee.
Okay.
Thank you. Judge Carter?
Well, I too have a lot of questions that we'll submit, I suppose. But let's just start. I think the question was asked, maybe it wasn't answered completely. Okay, we're here to, if we just had a magic money wand, which we don't, then we could wave over the issue of women's health. Can you be specific as to what your needs are, where we should target extra money to try? I think that's what the chairman was trying to get to too.
Yes.
And if you don't, but you can get specific in writing, that would be a great thing to do, because we are all very serious about this. This is the new wave of the military, and we've got to get it right. I know you've got a shortage of primary care doctors. Is that part of the issue, female primary care doctors? Do you try to put women with women doctors? That's a question I assume, but it may not be true. That's I think one of the things I like to ask about. So I'm going to make this hard. I just went through with my daughter and two of my daughter-in-laws fertility treatment. And I can tell you that is a very specific and skilled talent area. And to do it right, there are only a few people in this country that do it right. Are y'all going to contract for that kind of treatment? Okay, good. Otherwise, you can be bumping your head against a stone wall. But the guys that are good are really good. Finally, we just made a move in Central Texas, and you may be familiar with it. We moved our women's unit out of Temple to Waco, and the number one reason for that move was that to get to their facility, they had to walk through all the men's facility, and it was very uncomfortable with that, and it caused some of them not to come. And so we plus most of our PTSD and other issues relative to PTSD were more close to Fort Hood than they were in Waco. So we swapped out. We sent the women to Waco and the men not men, but the PTSD to Temple. Are y'all aware of that, and how's it working out?
So I'd like to address your questions probably in order. I would like to get back to you about some of the areas in which we have gaps, and we can describe that in writing. It's multi-determined, though, and the need for primary care providers in women's health is critical, and retaining the ones that we have. You know, the issues about, that you heard some, I think, yesterday from the Secretary, Dr. Stone, about retention, the pay, the incentive pays. These are issues that we have difficulty with. Retaining our women's health providers once we get them in place. Recruitment in many rural areas is extremely difficult, and we have gaps. A lot of this issue about not having enough providers in the rural clinics is about recruitment. So those are some issues, and then there's issues about just the entire program and having enough of the right kind of support surrounding the women's program. So I'll be responding to that. In regard to fertility treatment, you're absolutely right. It is contracted out through the Choice or the Mission Act, or the kinds of contract procedures that we have, because it is a very specialized, complex procedure. And I am very aware of what you've done in support of the Temple and Waco moves, and you know, it brings up an issue about making sure that the culture of VA changes to be better for women. We can't always move a site or the kind of program that we want to do. We have to improve through the work that we're doing with veterans and staff to make sure that the culture is safe, respectful, and civil, and that women do feel secure. And we're doing some major efforts on end harassment of veterans by veterans in order to address this issue of what is the culture like in a VA hospital. So both answers are there. We can sometimes make specialized services.
And that was the issue.
That we are making specialized services, but women veterans really don't want to just have a separate place. Women veterans want to be in a place where they are welcomed, like every veteran should be welcome, and that they feel secure and comfortable and respected in that setting. So we're working on that.
It's kind of like the construction site when the woman walks by.
And then that should not be when you come to your medical appointment.
Yeah, it should not. And
Right.
that's why Sandals got on it, and I think we did the right move. Waco has got more availability of space than Temple does.
And just to add, we've connected the Waco staff that now staff the new unit with our national MST support team. And so they're making sure that they get the proper training and education to make sure that that treatment program is of the same caliber as it was in Temple.
And we're hoping that will become a center of excellence for that. That's what we're looking at when we had our conversation.
What I hear from there is there's a lot of enthusiasm in Waco that the construction of the facility looks very nice, and people are really excited about it.
Well, good. Well, thank you.
Thank you very much, Judge Carter. Madam Chair?
Thank you, and thank you for coming here today. A few years ago, a veteran in my district went to the VA medical facility in her third trimester of pregnancy and was turned away because they had never seen a pregnant veteran there before. She was sent away without the necessary referral. I don't know what she was doing in the two trimesters. In a piece of VA literature on women's veterans under a section titled "A Promise Kept," it says that your local VA facility has a full-time women's veterans program manager ready to assist you in getting timely access to the health care you need. Now, do VA facilities other than medical centers have a women's veterans program manager? And if not, is there at least someone trained to assist veterans in referring them to the appropriate care so what happened in my district, frankly, never happens again? Have you heard about that before? Yes.
Madam Chair, I'm always discouraged when we hear of these incidents in which the improper care has been, been delivered or not delivered in this case. We do have someone at every site, so that while there's a women veteran program manager at the main hospital, every CBOC has a women's liaison who's trained up in all these issues. It's often the nurse there or other assistant that is there at the CBOC, and we make sure that they are really trained up in these things. Since several years ago, we've rapidly expanded our maternity services and our maternity care. We have a maternity care coordinator. So if someone comes into the VA, regardless of their time that they're pregnant. And we know across the U.S. and in VA, about 50% of pregnancies are unintended. And so that may mean that people are a little surprised by their condition and end up delaying care. So they come into the VA, we make sure they get assessed physically, they get all of the testing, they get started on things like the vitamins that they're going to need. We assign them to a maternity care coordinator. We get them care in the community as soon as we possibly can, and someone like that would be an urgent, appointment. And then we follow them both through their pregnancy, calling them up. If they start in the beginning, they're called every month, and or more often, and we get them lactation help, and we get them everything that they might need to have a successful pregnancy. And we make sure they have an appointment when they come back to the VA after their postpartum care.
Sounds good to me. I guess there was.
We've had some
something
improvement
happened
since
here.
that happened, yes.
Oh, you do? You're aware of that?
Well, I wasn't aware of that particular one, but unfortunately, bad things happen sometimes when
Right.
people are not trained up correctly at the VA.
Thank you very much. Thank you, Madam Chair.
Making sure we have consistency of service and awareness of the way that we should be dealing with women veterans is important. Mr. Rutherford?
Thank you, Madam Chair, and thank both of you for being here this morning. Dr. Hayes, well, actually, to both of you, you mentioned this 154% increase in women veterans accessing VA mental health care in the last decade. I noticed also a 297% increase in MST. Has there been any kind of study to link those two together, see how much of one is, how much of the mental health treatment is a result of the MST?
What we do know is we have a universal, sorry, I got so excited to answer this. We have a universal screening program when every veteran comes in, and it's just 2 questions that says, while you were in the military, were you sexually assaulted, or while you were in the military, were you sexually harassed in a threatening nature? And if you answer yes to one or both of the questions, then you're automatically told that you can receive free mental health or physical health care. And since we've been screening this last fiscal year, 29.1% of the women who have screened have indicated yes, that this did occur. The numbers have been slowly creeping up. At one time, we were saying 1 in 5, 1 in 4, and now, as you see, at 29.1, we are moving forward. One of the good news stories out of that, though, is we're seeing an increase of those individuals who then say, yes, I want treatment for this experience. And last year for women, it's 80.8% of our women. And that number has steadily been increasing. So I think women are getting the good news that there are quality treatments available within mental health. So you're right. So many of our women that we see are have mental health disorders. Military sexual trauma in itself is not a diagnosis, but there's many diagnoses associated with it, like post-traumatic stress disorder. So the majority of our women who have screened do suffer from PTSD or depression or addictions or things like that.
And the outreach must be, and the education piece must be pretty effective, because they don't have to show up at VA for any other healthcare issue to be seen for mental health as well, correct?
Right. I mean, if they just want MST-related treatment, yes, that's. But certainly, we find that many of our women who do experience MST have other medical and mental health issues, and so we have a lot of coordination of care. That's one of the good aspects of having VA. So it's likely that they would need other services while they're there.
Just good job. However, there are 24 of the 160 VA facilities that don't have gynecology care on site. Is it because of where these facilities are at, or can you talk about that a little bit?
Certainly. We have gynecology on site at the majority of our facilities. Those that do not are the class of facility that generally doesn't have even surgery on site. And gynecology is a surgical profession, and so they need the surgical service to have a clinic and to be able to perform procedures on site. Those women who are at those sites are seen by gynecologists in the community. And because these tend to be fairly rural sites with widespread veteran locality, that actually is better for the women to be able to go to a gynecologist closer to where she lives, so she won't be traveling a very long distance to a facility, which wouldn't make sense. We need to give it to her where she lives in those cases.
So it's not really as much related to a lack of OBGYN doctors as it is kind of the location and.
Well, the
what you-
location frequently is one in which we have difficulty even finding,
Right.
an OBG or a GYN. There are GYNs that will do office work, and we would love to have them come in and do some of the care in those sites, but then you become the recruitment in a highly rural, small town where you may have one person and they're working at, the community hospital.
Yeah.
So we will use the mission and choice options to send the veteran to the community. But
Okay, and-
again, the coordination is critical.
Yeah. Last year, the Service Women's Action Network called for the establishment of social groups for all women at vet centers. How have we done on bringing that together? Is that,
Vet centers have a number of different counselors, of women veterans who are counselors there. I don't think that you'd have to get back to you about whether the vet centers implemented that. There was also, maybe confusing, was a call for peer counselors. That was part of a legislative request. So we may need to clarify your question there, sir, in terms of exactly what it is that we can
yeah,
answer.
they were trying to establish peer support groups at each facility. And I guess that's part of the positions that you talked about before, the women's,
There's a women veteran program manager, that's a VA
Right,
employee.
right.
Peers are also employees, so.
sorry. Sorry, Madam
The
Chair.
gentleman's time is
My
expired.
time is up.
Sorry. Thank you. Mr. Bishop.
Thank you very much, Madam Chairman, and thank you, Dr. Hayes and Dr. McCutcheon, for your work, and thank you for appearing before us this morning. You've touched on a lot of the issues already that I had an interest in, but let me go to a little different slant here. A lady by the name of Gail Lemon wrote a book entitled Ashley's War, the untold story of a team of women soldiers on the Special Operations battlefield. It's about a team of servicewomen that were recruited by Special Ops to serve on combat missions in Afghanistan. And she paints a picture that while a record number of women have been going to war since 9/11, their war stories haven't really caught up with the pop culture. And that pop culture plays a huge part in any kind of change in America listening to their stories as women veterans. We often think of Special Ops as a male-based operation, but I know that that's not always the case. And as an example, I was enlightened by one of my military fellows who told me that when he was deployed to Afghanistan as a platoon leader, Special Ops personnel often sought out assistance from the female soldiers to go on missions with them to conduct searches of local females during various operations. So I wanted to ask you whether or not the Department of Veterans Affairs has any special programs that work with female veterans who may have endured those kinds of stressful deployed circumstances that required them to experience that working with Special Ops. And my second question, just to put them both together, since my time is limited, I know other people would like to ask questions. In your written testimony, you state that the VA is aware of the challenges that are faced by veterans with children with regard to access to their medical appointments and other medical care counseling and caregiving services. And of course, that is stressful for a veteran who's a single parent and who's dealing with PTSD. Do you have facilities at the VA clinics to accommodate children that may have to accompany the single parent to the medical appointments while they wait for their care? And of course, do you have also special programs to deal with the high-stress female veterans who have been exposed to that combat exposure in theater.
So I'd like to address that question second, actually, because the child care one is more straightforward. Child care is not, let me back up, VA is not authorized to provide child care to veterans because it's not medical care, the Office of General Counsel opinion in 2009. And we have, with Public Law 111-163, we have carried out the pilots in child care. Those are limited to 4 sites, and there's been expiring authority.
Can Congress help on that?
Well, I think Congress has passed a bill, H.R. 840, this past week, so I will defer to your wisdom on that, and we can answer any questions. The other question about experiences in the military and combat and things that I think both physical and emotional experiences related to combat are things that we are addressing, and we could go into some detail about some of our PTSD programs do have combat components or combat sequences where our these are women's programs that they can go through in terms of their combat experiences. Yeah, I want to let you ask what you want to ask her.
No. I appreciate that, the answer, to know that you do have those programs. But getting back to the child care, it seems to me to be an added stress for a single parent female veteran to have to go to a medical appointment with child or children and have to keep up and manage that child while they're waiting or while they're actually having care. And if you're limited in terms of what you can do with regard to providing child care for female veterans, or for that matter, any veteran who has to come get treatment and bring children, we in Congress do have the authority to give you permission to do that and resources. But we need to know that it's needed.
Thank you, ma'am.
Thank you. Gentleman's time's expired. Mr. Hurd?
Thank you, Madam Chair. Just to put a finer point on this, I'm the rookie on this committee. To be clear, can you use more money?
I see I've gotten myself completely boxed in. This is a discussion that...
Let me rephrase the question. If you have increased your people coming into your facility by a factor of 3 since 2001, could you let this committee know what a factor of 3 increase in your budget would actually look like and which programs that would require? And the question is for you, not for the Secretary of the VA.
I understand, sir.
Thank you. Awesome. Texas has more female veterans than any other state, about 820,000. And my second question is on non-traditional therapies. There's a group in as an entity in my district called Pink Berets. They do equine therapy, cooking therapy. They do gender-specific group therapy. How can non-traditional care like that be better integrated into what the VA does?
We are always pleased when we hear about these wonderful community resources like Pink Beret. And so hopefully every VA medical center has a women's mental health champion now. This is something new in the past 2 years, and it would be their responsibility to do outreach into the community to find such programs like what they offer, because Pink Berets offers programming that is not available in the VA. And so some of these special resources, then it would
So
be
is that
lovely.
is that a function through the choice program where they get connected there through the VA and they should ultimately be seen as a choice provider, or is it more like a VA center? What is the specific style of program for those to be a tool that the Women's Health Champion can tell your veterans he can use?
The mental health champion. My understanding is Pink Beret is it's a nonprofit that our women veterans can go there for free. And so it wouldn't be a choice where VA is paying for services, but these are certainly services that can complement what is going on in the VA.
Right.
Or perhaps the person isn't really interested in therapy at this point, but would like to go into the culinary or feels that support group would be important now.
Okay.
So we have, every VA should be connecting with these types of community resources
Gotcha.
because we can't do it all
For sure.
by ourselves.
And I'm sure you're open to me following up and having some specific conversations on this particular program.
Absolutely. It sounds like an excellent program.
I'm glad we're having this harassment by veterans on veterans, but we are not there yet. And in the absence of getting there, we should not allow, and as Judge Carter alluded to, if women are not coming to get care because they are uncomfortable with the, co-gender, co-ed group sessions, then we need to address that, right? And we need to make sure that we're able to provide them the care that they need. What are y'all doing in the interim until we achieve this utopian state where this doesn't happen? What are we doing in the interim to make sure that they feel comfortable to get those resources?
I'll answer part of the question. We're working really hard on, and I appreciate your point. This is not there yet, that
We're far from it, because this is the
we're far from
biggest
it.
concern I hear from female veterans in my district.
And I can tell you that I have met directly with the visiting directors and the medical center directors, and we're holding everyone accountable about this gender and sexual harassment, and we're ending it. We have a major effort going on. And be happy to tell you more about what we're doing, but I also appreciate the other part, which you're saying that women-only groups would be the ideal, and I think that would be important in terms of mental health for Dr. McCutcheon to have a comment on that.
And, some women do prefer women-only groups for various reasons, but some of our women do prefer gender, mixed gender groups. And VA doesn't really promote one model over another because women eventually have to go out into their communities where there are men. And to have that opportunity to interact with males in a therapeutic, protected environment can be part of someone's treatment plan. So we don't want to reduce all the mixed gender programs. And sometimes we will work with a woman individually and build up some skills so then she may want to enter into a mixed
So
gender.
I appreciate all that, and in my 9 seconds left, we do recognize, though, that I'm not a doctor, I'm not a clinical physician, I don't understand these things, but if women are uncomfortable even getting that first step of treatment, and that's why they're not coming, I hope we recognize that. And yes,
Absolutely.
we are trying to get them to get back into society, if you will, but we have to address the problem up front, which is the biggest gap of why our female veterans aren't getting the help they
Yes,
need.
absolutely. Walking in is different than being in a therapy group.
Gentleman's time's expired, and thank you, Mr. Hurd. I agree, and it should be
Yes.
it should be the veteran's choice, and there should be choices. Mr. Case.
Thank you. First of all, I'm walking along the same path as the chair, the ranking member, Mr. Hurd, as well as everybody else, which is, this is us asking you what you need. And, to me, looking out into the future 5, 10 years or longer, this is completely predictable. You've got, 10% of the vets now are women, but 16% are, increasing numbers of women are going into the armed services. I mean, is there a actual long-term plan? I guess I would put it that way. And let's say long-term is only 10 years. Do you know today, within reason, what you think the number of women veterans are going to be in 10 years? What percentage of the veterans they're going to be, and what services they're going to need, so that you can start today to build up your treatment services and to request funding over a period of time that shifts the funding mix possibly over a little bit more to emphasize the needs of a growing disproportionate population as compared to now. So we can see where this is going. And I'm just curious, I guess, I don't know where I'm going to be in 10 years, but somebody's going to be sitting in the chair 10 years and go, well, why didn't you do this 10 years ago, start down that path? So are you starting down that path? Do you know this with specificity?
Yes, sir. I started on this path 11 years ago. In fact, somebody showed me a speech that I made way earlier in my career that I said by the time I retire, I thought women would be 20% of the veteran population. So I've been running on this ramping up for quite some time, and VA has very good projections on enrollment and now on utilization and by zip code. We know what we need. What we really
How far
need,
out do those projections go?
They actually, the ones that go with exact numbers are 30 years, and then there's 50 years. I mean, there's actuarial projections that we work with local facilities on these projections. So the real issue, there are many other issues, but one of them, as you spoke to, is really about shifting resources. Unfortunately, the World War II veterans are passing on, and the Korean War veterans are just behind them. So the issue, as we replace those physicians and other staff, that's part of the projection as well. Right-sizing the resources, moving them from some of the other programs, and making sure that people are trained up. That's why we train up so many providers. They've been seeing men for a long time. They're uncomfortable with prescribing things like birth control. We train them to do this and to do exams and to do infections in women and things like that. So part of it is not just more money. It's making sure that we are getting the right force in there so that we have people who are designated women's health providers actually taking care of the women. And that's the program that's going on now. And we've been doing it really, really hard. We have many, many more than we did. We have 5,800 more than we did a few years ago. But then there's turnover, and there's more women coming in the door. And so it's really, as you say, are we doing it not for 5 years from now, but are we doing it for tomorrow and 6 months from now when your site might have 1,000 more women than they have today? And that's the sort of in the weeds part of it that is hard to implement.
Okay, well, that's really good to know. So one quick question. Do women utilize VA healthcare more than men, generally, or less?
Women need more visits than men do. And because
Well, my question is, are they in the VA healthcare system disproportionate to men?
No, they underutilize, about 10 points lower than men in terms of those who actually come, who are eligible to come, who come.
Why is that?
We've actually grown from a gap of a greater gap than that, and so more and more women are coming and staying. But the reasons they don't come, we have a lot of research. Number one reason is women do not know they're eligible. They don't identify with the word veteran. They don't know that VA benefits for them. And the second reason is they think VA is your father's VA and doesn't have women's health services.
Right. Well, that would beg for more women-directed outreach.
We do a tremendous amount of outreach. We have a call center that calls women who do not use VA. We've actually made calls to about 1.2 million and reached about 600,000 in the last 5 years. We think we have to do a lot more outreach, but we are doing outreach as well. That's part of the effort to increase the number of women who utilize VA.
Okay, thank you very much.
Thank you.
Thank you, Mr. Case. Mr. Cartwright?
Thank you, Madam Chair. Well, thank you both for being here. Since the passage of the Women Veterans Health Program Act of 1992, we've obviously been playing catch-up to provide women veterans with gender-specific health care services from the VHA. Here's my question. Is there a way of quantifying in any way this closing of the care gap when it comes to women's health? And can VHA give us more than just a general report on the gap closing that still needs to be achieved?
I think we can give you numbers on how many providers are at each site and how many we need. Can't always tell you all the reasons for that gap. We have that very detailed gap analysis. I'm not sure exactly what else that we can describe for you, sir, that would be helpful in this case.
Well, I'd like to see, I'm a numbers guy. I'd like to see an XY chart to show, are we closing that gap and how rapidly, and are we doing a good job at this?
We do produce these reports on where we are, the status today, where we've been is less important than the need going forward. So in terms of, we can show you enrollment projections and utilization projection gaps and where we are with the providers to meet that.
Well, then I'm going to get back in touch with you.
Very happy to brief you on it, I think, because the numbers help drive us to doing the right care and filling the gaps more quickly.
Exactly. Thank you. That's all I have. I yield back.
Thank you, Mr. Cartwright. Ms. Pingree?
Thank you very much, and thank you so much for being here today and the work you do to support our women veterans. I really appreciate it. I'll try to be specific, and you've already talked a lot about MST, and it's really unconscionable, the number of women who experience MST, and I'm happy to have the expert here with us today, so thank you for that. Let me just read some of this so I get it right. The VA has recognized that MST is a valid basis for claiming service connection for disability, and in 2002 created a relaxed evidentiary standard for claims following MST, which by its nature does not generally end up in service records, and you mentioned that. As written, however, the relaxed standard is only available to those diagnosed with PTSD, not to those diagnosed with other mental health disorders, and this is something I'm putting a lot of focus on, really on the benefit side. And while I know you're on the mental health professional side, I guess I'd just like you to speak a little bit to the range of mental health disorders that sexual trauma can cause, including major depressive disorders, anxiety disorders, I know you've already mentioned through, as well as the newly recognized trauma disorder defined by American Psychological Association, it's DSM-5. So I think what I'm looking for in your professional opinion, do you believe it would be appropriate for Congress and for the VA to provide uniform standards so that all veterans who are diagnosed with a mental health disorder due to sexual trauma during their time of service are then eligible for claims of disability benefits with the same evidentiary standard? I hope I've made that clear. Basically what I'm saying is you can't qualify for benefits unless you exhibit PTSD, yet we know, and I'm sure you know, that there are other things that people might exhibit. And I realize you're not in charge of benefits, and you may not even want to be quoted on this, but
Thank you,
it is the
thank
mental
you.
health professionals who should be making this decision.
Yes. And you're absolutely right. Although PTSD is the most prevalent disorder, we see, as you mentioned, depression, addictions, anxiety. We're doing a lot with eating disorders. and we
You mentioned
certainly
that,
see
yeah.
a lot with MST. And so, being a longtime VA employee, I am taught to stay in my lane. And it seems like that is more of a VBA issue, but certainly it has been well recognized that MST is not just PTSD with a sex base.
Yeah.
I mean, I think that we've come a long way in understanding what goes on with our men and women in this experience. So I think people are well recognized that it's more. And so I think, I don't know, Patty, if you have any more comments to that, but that's something that I think is well established, and you'd have to please toss that back to VBA.
Right, and just so you know, I'm working very hard on that, on the benefit side, and I don't, I fully understand it's not your lane, but I do appreciate, if for no other reason but that you're validating my concern, that we're saying to women, okay, only PTSD and everything else, sorry, go on with your life and good luck. So thank you for that.
And as you know as yourself, everybody has a similar experience, maybe a car accident, and one person reacts one way and one person reacts another way. Not to at all equate car accident to something that these men and women experience as far as MST. But, these, reactions are individual, and we respect that. And I applaud you for what you're doing.
Well, and thank you so much for the work you're doing. We really appreciate it. I'll yield back.
Thank you, Ms. Pingree. And batting cleanup, Mr. Ryan.
Thank you. I'll be brief because I know we've got to hustle up. First, I want to say thank you for your leadership all these years. Much appreciated. And to have two dynamic women here pressing the committee and the Congress is very, very important. And you have a big ally and a very dynamic woman who's the chair of this committee. And so I feel like we can really move the needle on this. So thank you for that. I'm going to throw a couple things out. I'll submit them for the record. I want to follow up on Congressman Hurd's question about the outside treatments, the outside groups that can help with some of this. I do a lot of work around mindfulness-based stress reduction, a lot of work around adverse childhood experiences, and I think it would be smart for us on the defense side, even before they become veterans, to really start to understand some of the trauma that happened before they even get into the military. We end up handling and dealing with a lot of that. So I want to figure out how we can get a more coordinated effort around adverse childhood experiences. We're learning more and more every day about them and the long-term impact. And the sooner we can figure that out for each individual, I think the better off we're going to be. Again, thank you for that. If there's anything that we can do on the side to work to help coordinate that, it'd be terrific. So,
just a brief comment, because I know you're in the Youngstown area. What we find in that area is you actually have a hallmark of dialectic behavioral therapy offered. within the Youngstown CBOC, which is which I wish we could provide at all of our VA medical centers. This is something that we hope to train up clinicians in the future, as well as you also have yoga there. So you are probably a few steps ahead in that you do have some of these.
I'm sorry, can you say that again? I didn't hear. No, I'm just teasing. I'm just teasing.
No, I'm very familiar with the Youngstown Warren CBOC.
Yeah, appreciate that.
But no, and the Women's Mental Health Champion, which is a new position. We just started with our Women's Mental Health Mini Residencies. And I will, I hope I don't get the shepherd's hook, but that's a collateral position. And so that's not like Patty's position where it's a women's veterans program manager, that's a funded position. And so that person has to do coordination around women's mental health in her spare time.
Right.
And so the MST coordinator and the women's mental health champion, collateral positions. They do that probably on their lunch hours. They do it whenever they can. And so, when you think
We
about
got it. We got an issue.
Probably get the hook from my VA people.
That's all right.
But, don't tell me when I said that, but that's something maybe you
Yeah, that's, and I'll just say quickly, I went out to the DCVA, and so yoga, mindfulness, these are not offered everywhere, as you know. Went to the DCVA when they just started it. A lot of Vietnam vets were there. Wished they would have found these modalities, treatments, techniques, whatever you want to call them, 40 years ago, because it healed them, healed their relationships, their health improved, the whole 9 yards. Went back a few years later, vets couldn't get into the classes because they became in high demand, and so they don't want to go on medication. They want to get some technique that they could take outside of the VA and work with themselves. So I think we found maybe the opportunity here. So thank you.
Let's really work together. When we write this bill, we have a lot of opportunities here, and that's why we've been focusing on these hearings where we can shine a little bit of a brighter spotlight on the issues that we don't normally get to spend time on, and so that you'd notice a theme. Thank you, Mr. Ryan. Thank you both, Dr. Hayes and Dr. McCutcheon, for your dedication to our women veterans, and I understand the restrictions of your ability to communicate and not be advocates here in front of the committee today. That's our job. So continuing to follow up and have discussions with you on how we can best meet the needs of our women veterans will be ongoing. So thank you. And that concludes this morning's hearing. I want to remind members that our next hearing will be on Wednesday, March 6th on VA's electronic health record modernization and general IT oversight. That hearing will be at 10 a.m. in 2362B Rayburn, and the committee stands adjourned. I'm running up to vote.